That way I could have an excuse to learn about it. So I picked worms. There's a lot of worms, and they're very relevant to a lot of parts of the world and not particularly relevant to us except on returning travelers. And, I guess we're experts. So if we get a returning traveler with some weird fever and a worm, we're supposed to be the ones that know. So I just wanted to go through everything really quick, so at least you would know the names and some of the basic stuff and some of the important stuff that may help you answer test questions. I have a lot of photos on purpose, and some of them are really gross. So I apologize in advance, and I'm glad we're not eating spaghetti. Although I secretly think that would be funny. So the big groups, nematodes or roundworms, flatworms can be divided into flukes and tapeworms. These are the ones we're going to go over. Again, they're going to be pretty quick. We're not going to go in depth on any of them. And then this is your handout. And I put it in the slides so that if you guys get this PowerPoint, you can print out the handout for study purposes later. So what do these worms have in common? And your handout is a clue. You can say, Elvis, and for your question, what do these worms have in common? That is correct. They all require a lung stage. So the larvae travel to the lung. So they enter the GI tract through either ingestion or through the skin, get into the GI tract, travel to the lung, mature there, and then you cough them up and swallow them to re-enter the GI tract. So all three of these worms can cause pneumonitis, eosinophilic infiltrate, pneumonia type of things. So we'll go through each one of them now. So Ascaris is the largest worm we'll talk about. It is ingested from fecal oral contamination, and it's very common. It affects up to 1/4 of the world's population on an estimate, and it's usually asymptomatic, which is what the worms like. They don't want to kill anybody. They just want to, hang out. So you get mild GI symptoms, maybe nausea, vomiting, abdominal pain. You do get intestinal obstruction because they're really big, but it's relatively rare. It's just that the worm is so common that even a rare manifestation is pretty common worldwide. It's especially worse in children because the worms are bigger in relation to the child's gut. They pass through the lung like we talked about, and the treatment is albendazole or ivermectin, which will be a recurrent theme through all of the roundworms. Here is the worm on a ruler. It's pretty big. Here is the same thing in the GI tract, also pretty large. The life cycle describing through the lung there. Crawling out of your nose, they migrate around, so they can migrate into the stomach, and then you can regurgitate them up. And so if somebody says, I coughed up a worm or a worm came out of my child's nose, this is the worm they're talking about. A large worm load here after getting some ivermectin. This is a male and female. These people are really proud of what they've done for this Indian village, and they collected all the worms and put them in a pile. I think they must have done it in the 70s, judging on their hairstyles. Here's some, sorry guys, these are pretty bad. They get a little better later. Intestinal obstruction with worms, and then spaghetti. So that's not us. Okay, moving on to hookworm. Usually when you say hookworm, you think of the worm Necator americanus, but it also can refer to Ancylostoma duodenale. They're both referred to as hookworm, but we'll just talk about Necator americanus. They're very similar enough that they don't have to be discussed separately. So in this bug, the larva penetrates the skin, so wear your shoes. The life cycle is very similar to Ascaris. Mild GI symptoms. These guys feed on blood, so they secrete an anticoagulant, and they can cause very severe anemia. That's what's unique about the hookworm. So all the symptoms of hookworm infection are related to symptoms of anemia. So malaise, fatigue, weakness, and even as severe as, say, high output cardiac failure, all from severe anemia. And so here's the mandatory life cycle slide. And then here's a microscopic view of the worm feeding on some of the intestinal mucosa. and they actually secrete an anticoagulant, and then once that area becomes necrotic, they leave and go somewhere else, and that area still bleeds, so that contributes to the anemia. And they're relatively small. They're a lot smaller than the ascaris. So strongyloides, this is a big one. It's pretty important medically, and we can see it here in the United States. It penetrates skin, similar to the hookworm, and the larvae mature on the lung. So if you're concerned about this, you can do a sputum O&P to look for the larva there. And then this is sort of unique because you get a chronic autoinfection, and so the larva, instead of passing out into the environment and then being repicked up through a fecal-oral route, getting picked up through the skin by walking on it, you can actually auto-infect yourself, so they'll actually crawl through the perianal skin and then you can get reinfected that way. And it's endemic in tropical areas, but also in the southeast United States. So that's us, but it's not really us. It's like Appalachia, North Georgia, South Carolina, those types of places. It does have an association with HTLV1 and any type of immune suppression. On an agar plate, you may see it crawling around and dragging the bacteria with it, making a sort of a characteristic pattern. And then if you want to diagnose it, this is really a theme for all the worms. All the serologies are positive, and then they never become negative. So if you were a traveler and you go to an endemic area and you come back and you have, strongyloides antibodies or ascaris antibodies or onchocerca antibodies, chances are you have an infection if you're having symptoms. If you're in an endemic area, antibodies make no difference because everybody's going to be positive, so they're not very helpful. And then with all the roundworms, treatment is ivermectin and albendazole. What's significant for us, especially in our transplant populations, is you can get a strongy hyperinfection if the patients are immune suppressed. So what happens is you get low-level autoinfection plus an immune suppression event. So steroids and transplant medication are pretty key. You get larvae penetrating everywhere and multiplying everywhere. So they penetrate the GI tract. They squirm around and drag gram-negative rods into the blood. They get into the CSF and crawl into there and drag gram-negatives with them that way. You can get a severe pulmonary infiltrate and respiratory distress. And so these people can get real sick and go into septic shock. So what you need to do before you immune suppress somebody who is at risk of this is screen them with serology. If serology is positive, treat them with ivermectin. Ivermectin is pretty well tolerated. It's not a big deal. And this is actually on our transplant protocol here at Tampa General. So that's something to keep an eye out for. Pictures of strongyloides. Here's what the little guy looks like. The life cycle. Some more microscopy. Here's a sputum sample with the larva on an O&P of sputum. And so that's it for that group. So those, again, were the three that have a lung face. So that was ascaris, hookworm, and strongyloides. So what do these worms have in common? For your question, Sally? Correct. They only have a very simple lifestyle. So they're just fecal-oral. So you eat fecally contaminated food or water, and then the eggs hatch and produce worms in the GI tract that lay eggs and go into the environment. There's no use in affiliate with these two bugs because there's no tissue invasion. So first, whipworm or Trichuris trichuria. It's the same non-specific GI symptoms, mild abdominal pain, possibly diarrhea, constipation. What's unique about this bug is that it can cause rectal prolapse, the typical coconut cake rectal prolapse, and you can also see a Campylobacter or a Shigella co-infection. That's sort of typical with this worm as well. You diagnose it with eggs in the stool, and they look like little footballs, and treatment is albendazole. I would imagine that ivermectin would work as well, but albendazole is in the books. Here's the whipworms along some intestinal mucosa. Here's the coconut cake rectal prolapse, and those are all little adult worms there. That's gross. And then microscopically, you can see the worms there within the intestinal mucosa. There's the eggs. They look like little footballs, kind of flat on the sides. There's not too many characteristic eggs. They all kind of look the same to me, so I try not to mention too many, but I thought these were sort of characteristic. The male and female worms, the females are always bigger in parasitology, and that is Trichuris. So next is pinworm. So this is very common here in the United States, especially in pediatric populations. So the scientific name is Anaerobius vermicularis, and the females live in the cecum, and then at night they actually migrate to the perirectal area and lay eggs that are very itchy. So the kid or even the adult has a really itchy behind, scratch. It promotes fecal-oral cross-contamination. An interesting thing about this one is it can cause salpingitis in women because the worms can actually migrate and crawl physically from the perirectal area into the vaginal canal. The diagnosis, you do a Scotch tape test and look under the microscope for eggs, and the treatment, again, is albendazole. So here's a rectal area showing some of the adult worms, and again, they like to come out at night, and nobody's quite sure why they like nighttime. Here's a microscopic cross-section. This is one thing you can get from playing in sandboxes, so be careful. Cover your sandboxes. That will be a theme later as well. And then the adult worm and the eggs and a cross-section along the gastric mucosa. The colonic mucosa. And you can do the Scotch tape test like this, or actually in some pediatrician's office they'll have like a sticky wand that they'll use instead of Scotch tape. And then the eggs look like this. These don't look particularly characteristic, but they sort of are because they're flat on one side. And so this is what you would see on a Scotch tape if you looked at it under the microscope, are these little flat-sided pinworm eggs. Very simple life cycle. Okay, so that's the first 5. We're getting there. Okay, next is Trichinella spiralis or trichinosis. So this is one of the reasons to cook your meat. So it's mostly associated with eating raw or undercooked pork, but it can really be any mammal. It has to be any carnivorous mammal. And the larva is in the meat. So then when you eat the meat encysted with larvae, they mature. The adults live in the intestine, mate there, and then lay eggs. The eggs hatch, and then the new larva encysts into your own muscle, and it's into skeletal muscle. So when this happens, you get fever, painful myositis, myalgias, significant eosinophilia, and there is an association with periorbital edema. You get high eosinophil count and a high CPK, but the ESR is normal, which is sort of interesting. Splinter hemorrhages. It can also go into the cardiac muscle, and so you can get cardiomyopathy. So if you have a cardiomyopathy in a traveler or a person from an endemic area, plus eosinophilia, you have to think of trichinosis. Diagnosis is by deep muscle biopsy, and the treatment is albendazole and steroids to help with the myositis. Here's some of the organisms in striated muscle. The life cycle involves pigs, and it can involve rodents as well. So that's it for trichinosis. So Dracunculus medianensis. This is another gross one. It is acquired by consuming contaminated water. They mature in the GI tract, and then after some time, about a year or so, the female migrates to the skin and actually sticks her uterus out and lays a bunch of eggs, and it's stimulated by water. So they'll wait until they're in water and then release all the eggs. So there's really no pharmacologic treatment. So the treatment is to, on a public health level, is to keep people who have a worm from getting into public water, water sanitation efforts, and then the treatment for the person who actually has the worm is to carefully remove it by winding it with a stick, which is apparently very long and painful. If you break it, then you're in trouble. And you can stimulate it to come out by soaking it in water. Then it'll come out and you can grab it. So here's the worm and the stick. It's been around for a long time. Here's a 9th century painting. Here's another photograph of posterior calf. Oh, by the way, the other name is a guinea worm. So this is a guinea worm. And so what happens when the worm first starts to come out is it'll form a blister, and then the blister will rupture, and then that will be where the worm is. There's the life cycle with the eggs being released into water. And Dr. Cho, one of our co-fellows, said, oh, well, this is where the medical symbol comes from, is because you wrap the caduceus, you wrap the worm around the staff, and that's completely untrue. It's just a total farce. That is actually some rod of Asclepiades or something, but you'll hear that kind of myth. That's where that comes from. Okay, on to filariasis, and this area in particular was a mystery to me before I started going over, but it's really not that complicated. The organisms are pretty big adults, and they live somewhere in the body depending on which one, and then they have microfilaria which get into blood, and then they're transmitted by bites, fly bites, and they're highly evolved, unlike some of the flatworms and stuff we'll talk about. They have a very complicated life cycle, and you really only get symptoms from a chronic infection. So, like, if you just go somewhere and get bit by one of these flies, you're really not going to get elephantiasis, you're not going to get urinary symptoms, you're not going to get anything significant. It's really only if you live in endemic areas where you get a really high parasite load. Here's a complicated lifestyle, the complicated life cycle. So the first one we'll talk about is onchocerciasis, which is also called African river blindness. It's really a skin disease first, and in travelers, that's really the only thing you'll see is a skin disease. So you get bit by a black fly, and then you get an itchy rash, and the rash is from all the microfilaria in your skin. And it's kind of hard to diagnose in travel clinic because the rash comes and goes, and it's sort of vague, and then you say it's real itchy, but then by the time you see the doctor, it's gone, and then it comes back later. In chronic skin disease, you can get loss of skin pigment, which is called leopard skin, or hanging groin. That is also sort of a symptom of chronic skin changes. And then eye disease is really more of a severe, long-standing problem if you have a high parasite load. So, again, it's acquired from the bite of a black fly, and then the microfilaria travel to the subcutaneous tissues for onchocercovolvulus. That's where they go, is the subcutaneous tissues, and they mature into adults there. And then the circulating microfilaria, which are the offspring, cause the itchy rash skin symptoms, and then deposition in the eye causes the keratitis, which eventually leads to blindness. Here's the black fly. Here's your itchy red rash. Itchy chronic skin changes in a person from an endemic area. Very itchy. And then what you get are these subcutaneous nodules, and so you have nodules, and if you actually cut open one of these nodules, you have the adult worms. And so you can see them, and these nodules are full of worms. And then in the eye, you get microfilaria in the eye. This is a slit lamp exam photo. And then from the chronic inflammation, that's where you get the eventual corneal scarring and blindness. So here's a corneal scar. Can't really see it too well. Some chronic eye damage. Some women who have been affected chronically. And then this is a statue at the World Health Organization headquarters, and this is a boy leading around his father with a stick because he's blind. And this is sort of representative of an initiative to really clear this infection, because it is a very reasonable thing to treat and get rid of. So to diagnose it, if you're a traveler, serology is fine. But if you're from an endemic area, you do a skin snip, and you can see the microfilaria there. There is something called the Mazzati test, and what you do is you give diethyl carbamazine, and it'll make the itchiness worse if you're infected. But if you give it to somebody who's really very infected, you'll get a severe reaction, and so that's kind of not the best test, but it is used sometimes to help decide who has an active infection. The treatment is ivermectin, probably plus doxycycline. I wrote or, but it's really both. And then the reason that you use doxycycline, this is interesting, this is sort of a point for all filaria, is that the filaria have a symbiotic bacteria called Wolbachia. It's a rickettsia-like organism, and the filaria require the Wolbachia to live. And so if you can kill the Wolbachia with doxycycline, which is a very cheap, very well-tolerated drug, then you can kill most of the adults. So the ivermectin kills the microfilaria, and then the doxycycline kills 80% of the adult worms. You need a long course of the doxycycline, and then you'll probably get most of them, but really what it comes down to is if you have a lower parasite load, then all these chronic problems that you get will be significantly reduced. So that was Onchocerca. So on to Wuchereria bancrofti. This is also called lymphatic filariasis. And then the other lymphatic filariasis is Brugia mallei. And again, kind of like the hookworm, they're very similar. In slightly separate parts of the world, do have some overlapping areas. So you can kind of think of Brugia as the same as Wuchereria. This filariasis is transmitted by mosquitoes, another reason to avoid mosquitoes, and most people are asymptomatic. And then in traveler, you don't have any symptoms. If you get infected with this, it doesn't really ever come up. And then if you have a high parasite load in an endemic area, the most common symptom is a hydrocele. So this is something that people won't tell you about. You have to ask. You have to do a very complete physical exam to see the hydrocele. And then for even more severe cases, you can get elephantiasis. Some people who are prone to eosinophilia and allergic reactions can get tropical pulmonary eosinophilia, which is asthma at night. So these people don't have any asthma during the day. They don't have any problem exercising, but they get asthma at night. And this is when the microfilaria migrate and circulate and cause some inflammation in the lung. And then if the adult worms live in the lymphatic system. So if they live in the lymphatic system near the kidney, they can drain lymph right into the urine, and you can get chyluria. This causes severe malnutrition, and it's a pretty characteristic type of picture. Here's your mosquito. Here's elephantiasis involving the scrotum and the leg. The reason that these chronic skin changes happen is the lymphatics get physically blocked by granulomas, and so then you can't drain. This is an old picture. I can't tell if it's a photograph or a painting, but it's pretty impressive. And then on the left is the chyluria, and the right is a significant hydrocele. To diagnose them, you do a microfilaria in blood that is drawn at night, because, again, they like to circulate at night. And then serology is available, but it's not well standardized and not really well used. The treatment is albendazole, ivermectin, DEC, and doxycycline. Again, all filaria have this Wolbachia that you can treat with doxy. So Loa eyeworm is one of the most impressive worms because it shows up at an impressive location. This worm likes to be in the subcutaneous tissue, so it migrates around through the subcutaneous tissue, and that is continuous with the conjunctiva. So it's just kind of crawling around, and then it just happens to crawl through the conjunctiva on the way to wherever it's going. But that is really when people notice it, and it's very distressing. The other symptom that you get from Loa is calabar swellings. So then you get localized angioedema of the limbs, hands especially. And then this disease really isn't serious. It doesn't cause any serious problems. It's just weird because you have this worm in your eye. You can treat it with diethylcarbazamine. Diethylcarbazamine. And then an interesting side note, if you use ivermectin, it can cause severe side effects with Loa, but I'm not quite sure on the details of that. And that would be something to look into, I suppose, if you were in an African travel clinic. So here's the calabar swellings. Some more swelling. And this is really the way to diagnose it, because waiting for the worm to crawl through the eye really isn't a reasonable thing. This is sort of more of a clinical picture that's more typical and easy to see. But then in the eye, you can get a physical worm, and this actually hurts because it crawls across your eye. It takes about an hour So while it's there, it's uncomfortable. And you can remove it, but you have more worms in your body, so why bother? Okay, that's it for the roundworms. So roundworms, well, we'll get to the treatment in a little bit, but the treatment is ivermectin and albendazole. Okay, on to flukes. These are less advanced. They don't have quite as complicated of life cycles. The first one the common theme for all flukes is snails. Snails is always an intermediary. So these are all acquired by either eating snails or eating food that has snail slime on it. So, or getting exposed to water that has snails around. So the common theme is always snails. This is in Italy somewhere. You can buy some if you would like them. Dr. Will says he wants the ones on the sign. So schistosoma is the blood fluke. It causes a dermatitis or swimmer's itch. Acutely, it causes a catamine fever, and then chronically, it causes portal system fibrosis and urinary fibrosis. So the way that you get this bug is by swimming in contaminated water. You actually get migration of the larva through your skin, so you get this swimmer's itch and a rash. Katayama fever is the acute infection, so you get hepatosplenomegaly, lymphadenopathy, fever. These things are all very nonspecific, so the thing you got to look for to differentiate is eosinophilia. So if you have all these things plus significant eosinophilia, it's schistosomiasis. So all of these other differential diagnoses, malaria, typhoid, leptospirosis, they're not going to give you eosinophilia. And then the other thing is hematuria is common early in the disease, and there's actually some talk about male menstruation where young boys, when they start working in the rice fields, get hematuria, and that's sort of expected. And there's, you have to explain, well, no, that's not normal. So fever plus eosinophilia equals schistosomiasis until proven otherwise, especially with freshwater exposure. So then the chronic form, you get fibrosis. You get portal fibrosis without cirrhosis. So you'll have all the symptoms of cirrhosis, but if you biopsy the liver, you're not going to have cirrhosis. So you get ascites and esophageal varices, gastric varices. You can also get urinary fibrosis with obstructive uropathy, chronic renal failure, urinary type of symptoms. And then the bacterial counterpart that's seen a lot is salmonella. Here's your swimmer's itch. Can't really see it too well, but it's just a palpable, just red papules. Here's a type of water you can get it from. It's poor living conditions, contaminated water. Lake Victoria is a hot spot for schistosomiasis. So if you want to get baptized there, beware. And then here's a child with ascites. So, this where I got this photo, they pointed out this could be from schistosomiasis, but it could also be from leishmania as well. Portal fibrosis and ascites. And then here's some more swimmer's itch. Here's the snails that are the intermediate host. And then one of the other public health things that you can do is get rid of the snails. So there are some efforts into clearing out the snails, and that does help reduce some of the schistosomiasis. Complicated life cycle. Mostly in Africa, but in other tropical areas as well. And then to diagnosis, you check the eggs in the stool or urine if you're endemic, and serology in travelers. Same sort of story as before. And now we've switched treatments to praziquantel. So we'll be seeing a lot of praziquantel for the next couple of organisms. And then in a returning traveler from an endemic area, they rarely cause some serious side effects, or serious symptoms like CNS problems. And every once in a while, somebody gets a spinal cord abscess and paralysis. So somebody who's from an endemic area with positive serology, just treat them. It's praziquantel. It's not a big deal. Just go ahead and treat them. Okay, so the liver fluke, Fasciola hepatica. These adult worms live in the biliary tree. You get them from eating, again, the snails or the plants that snails have been on. The acute symptoms are from the immature larva penetrating from the GI tract into the liver. So they penetrate through the liver. So you get severe right upper quadrant pain, fever, eosinophilia. And then chronically you get symptoms of biliary obstruction, so jaundice, recurrent cholecystitis. The trick with fasciole hepatica is that it's praziquantel resistant. It's really the only one that is, so you have to use triclobendazole. I don't know if they're ever really going to ask us that, but that's the only tricky drug question there is in this whole thing. Clonorchis and Alpisorchis are really more just liver flukes. They're pretty much the same. I just kind of wanted to put them in because I thought they had amusing names. And you can file them away. Same thing, kind of. Not worth getting into the details. There you go. All right, we're getting close to the end. Not quite, more than halfway. Paragonimus westermani is the lung fluke. This one you happen to get from eating freshwater crabs, especially in Southeast Asia. This is a high-risk eating behavior. Do not do this. And again, this is snails, areas that are contaminated with snails. The adult worms live in the lung. This bug mimics tuberculosis, so you get weight loss, hemoptysis, and a cystic lesion on X-ray. So that's something to think about in a person coming from an endemic area or traveling to an endemic area. You have to order specifically an O&P sputum. If you just order AFB, it will get destroyed. You can't do the eggs get destroyed and the O&P and the larva, so you have to order it specially. And the treatment is praziquantel. Angiostrongylus cantonensis. I really just put this in here for Dr. Green. So this is not, we are not the definitive host for this bug. This is the rat lung fluke. So this is a fluke that's living in the rat lung. But then if we're an incidental host, the larva can cause trouble, and they actually get into the CNS and cause any eosinophilic meningitis. The treatment is repeat lumbar punctures to try and keep the pressure down, and you can give steroids maybe. So then I went in the other eosinophilic meningitis bugs because we were talking about it. So Angiostrongylus cantonensis fits in with the flukes, but then Bailey ascarius and Gnanthostomiasis are roundworms. But they just like Angiostrongylus, we are not the definitive host, so you have to be an incidental host. And all of these cause bad outcomes. So these people don't do well. A lot of people, and they're very rare, so they're sort of should be low on your radar, but it's possible. This whole raccoon feces, this is another reason to cover your sandbox. Okay, tapeworms. So tapeworms are generally asymptomatic. They cause weight loss, vague GI symptoms. They're more primitive. They don't have any digestive system. So what they do is they cling on to your intestine, and then they really just absorb the nutrients through the external wall. They have proglottids. That's what gives them the tape-like appearance, and the proglottids are dropped off, and they contain mature eggs. And then those are released in the stool. So sometimes people will be like, yeah, I'm losing weight, and I have these weird things in my stool that I don't know what they are. Okay, well, you might have a tapeworm. When I've been eating raw pork, or whatever. Treatment for all of them is praziquantel. Here's a picture of a tapeworm. This is actually a dog tapeworm, but you get the idea. And then it's the tapeworm diet, which is actually not a bad idea. No diet, no baths, no exercise. The enemy that is shortening your life banished. How? With sanitized tapeworms, jar packed. So what you do is you take a tapeworm larva, it hatches, absorbs some of your nutrients, you lose a lot of weight, and then you just take a dose of praziquantel. I don't know, it's not the worst idea ever, but it's not FDA approved. So go to wormtherapy.com. Helminth, oh shoot. Oh. Uh-huh. And then slideshow?
There you go.
Okay. We'll see if I'm still recording. Then, worm therapy, Helminth-induced immune modulation. You can get hookworm, tapeworm, or combination therapy. And they were had an ad for psoriasis treatment or something, and it's weird. For MS? Does it work? I don't know. I don't buy.
Not bad. The outside.
So just a few tapeworms. Oh, if you actually Google if you Google tapeworm diet, you'll get to it. But I don't know. This was just something. Well, I don't. At the bottom of this website, it says these are not FDA approved therapies. So maybe you can. Yeah, I don't know. Okay, so a couple tapeworms. We're going to talk about three. Tinea solium. This is actually the most interesting one because if you ingest the larva from undercooked meat, you get a tapeworm. And a tapeworm is it's not a big deal. It may cause symptoms, it may not. If you ingest the eggs from food contaminated with pig feces, so like, salad rinsed with dirty water, or it's just a contaminated food, you can get cysticercosis because then you become this intermediary host, and the larvae try and hatch and mature, but they can't, so they just go all over and cause trouble. Then, of course, the most significant place that the larvae go are in the CNS, so you get a new onset seizure, focal neurologic deficits. You can get imaging which shows the cysticerci, and then you treat it with albendazole, steroids, and anti-seizure medicine, or you can just go in with like a ventricular scope and just pull it out and do those things. So I don't know if neurosurgery is really into that, if they'll do it, but I think if it's necessary, it's definitely possible. Tinea saginata is a beef tapeworm, ingestion of undercooked beef, and then you get a tapeworm. It's relatively benign, and again, the symptoms are mild, maybe abdominal pain, maybe diarrhea, constipation, and then seeing the proglottids in your stool, and weight loss. Diphyllobothrum latum, this was a favorite med school question, and this is from eating undercooked fish, and it causes B12 deficiency. This one in particular needs B12, so it absorbs all your B12. It looks like pernicious anemia. You get neuropathy, depression, ataxia, neurosymptoms, and this one can be up to 10 meters long. So I don't know, that must be in a big fish, or maybe us all wound up, but that's a big tapeworm. And then your fresh sushi isn't fresh because they freeze it so they can get rid of this organism, and I'm not sure what others, but this organism is killed by freezing. So all your sushi that you eat at restaurants have been frozen at some point. Life cycle involving fish. Okay, so treatment. It's really just one slide because it's very easy. So roundworms, ivermectin, albendazole. I'm not sure if the boards would ever ask us to differentiate between ivermectin and albendazole. I don't know if that's important or not, but a lot of times ivermectin's a drug of choice, but albendazole will work, or albendazole is a drug of choice and ivermectin will work. And then doxycycline for filaria. Flatworms is praziquantel. The only exception is for fasciole hepatica, where you need to use triclobendazole. So in summary, wear your shoes, wash your hands, cook your meat, avoid mosquitoes, be wary of snails, and don't go swimming in Africa. And that's it.